Hi, you guys. It's Dr. Baker Townsend, and I'm going to talk to you today about pain medications during labor. This is chapter 17, and we're really starting on pharmacologic pain management. This begins on approximately page 391. So the first thing, you guys, is that we really don't use any sedatives during labor. The baby gets the sedatives. We really think about major anesthesia drugs. We think about benzodiazepines, sometimes Phenergan. And so we really don't want our baby to get that. And you can kind of read a little bit about it on page 392 if you have any further questions. Analgesia and anesthesia. So there's systemic analgesia, and we only really give IV pain meds if the patient wants it, and it sometimes doesn't completely take away their pain. We can also give these IM. It's just that when we give them IM, they're a little bit less easy to predict how long they'll last, and it's kind of hard for redosing. So many times we give these IV. Usually we give these because the patient wants it, or there's a contraindication to epidural anesthesia, such as a MRSA lesion on their back, where they would go through to get to the epidural space. Spinal surgery, if the patient has had extensive spinal surgery or has Harrington's rods for scoliosis, or any kind of scar tissue, screws, plates, previous surgeries, we really don't want to alter that, so they really won't go in. The last condition is idiopathic thrombocytopenia. So during pregnancy, we already know that we're going to get more plasma than we're going to get red blood cells. So the extra plasma volume decreases the amount of circulating platelets. So sometimes they'll go down, and then for whatever reason the patient they'll really tank. The platelets will go under 100,000, and we don't know why. It's idiopathic. So when the platelets go down under 100,000, we are concerned because we know that there are veins, that we are doing a blind stick when we do an epidural when we do epidural anesthesia. And so if the platelets are low, and we know we're doing a blind stick, and we know that we could nick one of the epidural veins near the spinal column, we don't want the patient to bleed and cause a occupying of space that could press up on the spinal column and press up fluid, which could injure the spinal cord. So if there's not enough platelets, we are not going anywhere near the spinal area, just simply because we do not want to bleed, and we do not want pressure on the spinal column or spinal cord. So one of the ones that we give is fentanyl. It's a narcotic agonist analgesic, and the thing about fentanyl is people use it more now in labor if the patient is a candidate, because she's not fuzzy, but the baby does get some of the fentanyl. So it's a little bit better for pain relief, and it has less to do with your CNS, so it really just kind of relieves pain. So you'll see anesthesia come and push a small amount of IV fentanyl. We never want to give, we know that respiratory depression is a side effect of narcotics, so we never want to give, or we never want anesthesia to give our patient IV fentanyl an hour prior to delivery, because we know that not only will it cause maternal respiratory depression, it goes across the placenta, and it will give the baby respiratory depression. At the time of delivery, we want the baby to have the big vaginal squeeze and to come out and start crying, so that it can clear the amniotic fluid out of the airway. So if there's respiratory depression, the baby will not do that, and we could have a really bad situation on our hands where our baby's not breathing. Opioid agonist and antagonist analgesics, Stadol and Nubane, both of those work on the kappa receptors, and they block the mu receptors, so that decreases the pain impulse. So same thing. Stadol, though, the one thing with Stadol is that it causes you to be very lightheaded. It can cause you to hallucinate. We call it the truth serum. People start saying all kinds of truths that we don't want to know because they're uninhibited. And then Nubane produces like a morphine response. So same thing with these. We never want to give these 1 hour prior to delivery due to neonatal respiratory depression. And then what's really important too is safety here. You don't want this patient getting out of bed with any of these narcotics walking around. You want to keep them in the bed with the side rails up, bed in the lowest position, and the call bell in place, and because you just don't want to have an injury due to them being on these narcotics. Obviously, whenever you have an opioid that you administer, you need an opioid antagonist, Narcan. You always have it available if you're giving opioids. If you have someone that you suspect is a drug user and you give them Narcan, expect to see a major withdrawal response. So how do you tell if you're worried that someone could be a drug user prior to giving them some of these analgesics? On page 395, it says there's a little box at the bottom, it's purple, and it says signs of potential complications, maternal opioid abstinence syndrome. So when you give them Narcan and they are using, you can expect them to have yawning, rhinorrhea, runny nose, sweating, lacrimal tearing, and then dilation of the pupils, anorexia, irritability, restlessness, generalized anxiety, tremors. Tremors is the big one. Chills and hot flashes, piloerection, so they'll have like little chill bumps. Violent sneezing, weakness, fatigue, drowsiness, nausea and vomiting, diarrhea, abdominal cramps, bone and muscle pain, spasms, kicking movements, and you guys, if it's really bad and you give them, if they're, a serious abuser and you give them Narcan, they can go straight into a seizure. So, and remember, the baby could be used to having these medications on board, so that could hurt the baby as well. So you always use narcotics with extreme caution, and you always use Narcan with extreme caution because you could have a lot of trouble from both of those. So some nerve blocks that we have, you can get a local perineal infiltration anesthesia. So they just give you lidocaine on your perineum. Remember, that's the place from the posterior vagina to the rectum. And they use that a lot for repair. So if you have a tear, they can go ahead and put some lidocaine in and go ahead and give you a repair. Oops, sorry about that. A pudendal block. A pudendal nerve block is administered in the second stage of labor for pain relief. And actually I have a picture on page 396, figure 17.9. So what they're doing is they're targeting the pudendal nerve, and they inject lidocaine in this pudendal nerve. It should set up 10 to 20 minutes prior to a vacuum extraction of the baby and episiotomy or delivery. I have not seen these much in clinical practice. Epidurals are so very popular that you rarely see those. Spinal anesthesia. So you can have spinal anesthesia, and here I have a picture. So when you have spinal anesthesia, they go higher in the insertion site, and they go to the spinal column where the CSF is, and so they administer narcotics through this spinal column, and they will put the narcotics in there. When they go in a higher space and they give stronger narcotics, you can see this is going to give a higher level of anesthesia for a cesarean birth. So spinal blocks are used for cesarean birth, and you can see she will have great anesthesia all the way from her diaphragm, well, just below her diaphragm, down. We definitely do not want her diaphragm to be anesthetized. So she'll have great pain relief. Now, an epidural block, you're going to put in a little bit lower, and you can see that's around L5, and she'll have less block, but she'll have some blocks. Her uterus will be blocked, some pain relief here, and then she'll have some residual decreased movement in her legs for a vaginal delivery. So let's go back up to that one. So that was spinal anesthesia. The risk of spinal anesthesia is a post-dural puncture headache. And I'm sorry to go back and forth, but as you can see, when they put this spinal in and they go to the spinal column, this spinal fluid can also leak out when you take out this spinal needle that was used to put narcotics in the spinal column. So when you take this spinal needle out, you may have CSF coming out. And so when CSF comes out, and a patient is sitting up in a sitting position, then gravity pushes this CSF out. If you lay her flat like this, gravity is no longer pushing on her head, and the headache will dissipate because now she's laid in a flat surface. That's if she has a spinal headache due to leaking CSF. So how do we repair that? We just go and get a needle and pull 10 cc's of blood from her AC in her arm, change out the needle, put it on here, inject it into the epidural space, into where the spinal was put in. A clot will form. She gets a liter of fluid, and she's back in business. The headache will go away because the CSF is no longer leaking out. So that is your information about a post-dural headache and an epidural blood patch. You can do a blood patch for an epidural or a spinal. Now the epidural should not leak CSF, but if you go too far past the epidural space and go into the spinal column, then you can have a puncture and you may have to get an epidural blood patch as well. This is just a diagram depicting a pudendal block. So if they put in a pudendal block, it just anesthetizes this pudendal nerve. So it does not give any uterine contraction relief, and it may give a little bit of perineal relief. Whereas in epidural anesthesia, they come in here and you get the anesthesia gets into the spinal column. Of course, nowhere near the spinal cord. Because the insertion site is below the spinal cord, there is no risk for paralysis, and it bathes these spinal nerves right here, and the patient will then have decreased pain during the uterine contractions. What I would like to say is there are nerves and there are vessels all back here. When we do this blind stick and we thread the catheter in, the catheter might go left or right. So the patient may have better relief on the right side or the left side. So let's say the patient has more relief on the right side because the catheter turned right. The way to repair this is turn the patient to the left and let gravity push the medication to the left side, and it will bathe the nerves on the left, and then you'll have a better nerve block that's not one-sided. Yeah, this is just showing an anterior to anterior approach of the actual space. You can see the epidural space right here is which our target is. So pre-anesthesia, so epidural anesthesia, which is the most common that you're going to see. Nursing interventions prior to the procedure, of course, evaluate the skin on the back. Evaluate the history for any previous spinal surgeries. Again, they need to make a surgical consult prior to coming in for delivery if they've had spinal surgery. They need their records, they need MRIs, they need x-rays, so anesthesia can evaluate what's happened to them before so they can see if they are even a candidate for epidural anesthesia. Evaluate the skin on the back for lesions. Of course, they're never going to go through a MRSA lesion and introduce MRSA into the spinal column. Evaluate the CBC for platelets over 100,000. Obtain consent for general anesthesia and epidural anesthesia. The reason why we do this is because we do not know what's going to happen during this labor, and we want to be covered for general anesthesia if in case an emergency happened and they need it. So now you guys, the one of the big nursing interventions is you need to preload the patient with 500 to 2 liters. So some facilities, so 500 is very, very conservative. We would use this if somebody had extreme preeclampsia and we were worried about driving up their pressure. But normally, in most settings, it's 1 to 2 liters of normal saline or lactated ringers. The reason is because when we go into the spinal column, you get a blockade. It's called a sympathetic blockade that can decrease the blood pressure. So if the blood pressure in the mom is decreased, then that will decrease the amount of blood pressure going to the placenta, and that will decrease the mom's blood pressure. That decreases the amount of oxygen going to the gap to be picked up by the placenta. So you will see the fetal heart tones when mom goes into hypotension. The heart tones can go down and can cause fetal bradycardia and can actually cause an emergency C-section because the baby doesn't have available oxygen and there's an emergency C-section. I have put a little link here if you want to learn more about sympathetic blockade. So when we do the epidural, they're going to cleanse the skin here, go through the muscle, and the target is the epidural space. This is a negative space here. Of course, they don't want to go through the space and in the spinal column because you can get the CSF would leak out here and cause a spinal headache. Now, if the target was to do a spinal or intrathecal injection, of course, we would go a little bit higher, of course, well below the spinal cord, so that there's no danger for any paralysis. And it's a much smaller needle, and they inject it and then quickly withdraw so that they do not get a large puncture in the spinal column. They're just a very small puncture to deliver the medication and get out to reduce the potential of a spinal leak. So we have them sit with a knee chest position, or you have them sit on the side of the bed with their feet flat and with a pillow in front of them, and usually a partner sitting in a chair here in front of them. This is because we do not want the partner to have a vasovagal response and to pass out and give us 2 patients. So that's really important. So you guys, you can see how they're hunched over, how she's hunched over like this. This is to open up the spinal cord so that they can introduce the epidural between the vertebra. This one is post-procedural, and this is where they have the epidural was already, the back was cleaned, the epidural was inserted, the catheter came out, it was attached to tubing that connected to patient-controlled epidural anesthesia, so the patient can get very small mini boluses if needed. Now we're going to go see Cal Shipley, and this is the epidural procedure, and I'm just going to talk to you a little bit about it while it's a 4-minute video while he shows it. And so right here it is. Sorry, let me pull you around here. Sorry. So Dr. Shipley, he reviews epidural anesthesia in this video. So what's nice about epidural anesthesia is it is used when you want to keep the patient awake and you don't want to put them under general anesthesia. So what we do is they put in a nerve block in the sacral nerve roots that come off of the spinal cord, usually around L5. The spinal cord ends around the L2. So this is the cauda equina. So we're going to introduce the epidural lower than the spinal cord, so there's no risk for paralysis. So you can see that it's well below the spinal cord. Now you can see here's the muscle, here the vertebra, here is the epidural space. So if you look from above, here is the vertebra. Here is the epidural space around here. This is the dural covering. This is the cauda equina, and this is the dural covering. And then inside of the dura is the arachnoid layer. So we don't want to get into these layers. We want to go here in the epidural space. And this is a negative space. Okay, this is a negative space. There should be nothing in this space. The CSF flows in the in this spinal column. Now, in the procedure, they're going to go between L4 and L5. They're going to cleanse the skin, and they're going to introduce through the muscle between the vertebra, and they want to use a 2E needle to get to the epidural space. So you can see how this 2E needle is going against through this muscle. So there's pressure, pressure, pressure. When they put saline and a syringe onto this needle, once they get to the epidural space, since this is a negative space, the fluid from inside of the needle will see a release of the syringe because it's negative space, and it will go into the epidural space, and that's how they know they got to the correct space. Then they'll put an epidural catheter through the needle, and of course this is blind, and it's going to go upward. Hopefully it's straight and it does not go to the right or to the left, as we had discussed earlier. Now they're going to, and you can see here, and it's pretty straight. Sometimes it goes off to the side, and we have to turn them to the other side to bathe the other nerves. Now the 2E needle gets pulled out, and now a test dose will be given. So they're going to give a little bit of anesthetics, like lidocaine and some ephedrine, to inject to make sure that the patient can move her legs. They'll wait 3 minutes, and the test dose, they'll see, I'm going to say this about the test dose. The test dose has ephedrine in it, so that if let me go back just a little bit, has ephedrine in it. So if this was in a spinal vein, the ephedrine would get into the maternal circulation and cause the heart rate to elevate. So during the test dose, you have a pulse ox that's depicting that you can hear the heart rate. So during the test rate, if the heart rate goes up, we're very worried that it is in an epidural vein. Of course, whoever's providing the anesthesia, the CRNA or anesthesiologist, would withdraw and replace, because we do not want to deliver the ingredients of the epidural anesthesia, which is fentanyl and lidocaine, into a vein. That would defeat the purpose. Also, lidocaine, if it's given IV, can make the left ventricle not work as well, and that is definitely not what we need to do during labor. We need the left ventricle to work very well, because we know there's a lot of load on the heart due to the increased blood volume. So that was from the test dose as a perspective into a vein. Now the test dose as a perspective is not into the spinal column. So you guys, we want to make sure that this did not go into the spinal column or provide an intrathecal anesthesia. So now they're going to also give, they'll give fentanyl to see if it gets in the epidural space or it's in the spinal column. If it's in the spinal column, the patient will not be able to move their legs because it's in the spinal column. So if they can move their legs, that's a good thing. That means that there's appropriate epidural placements. So this means that it's a good, we must assume if they can move their leg, this is good. We're happy they can move their legs. So if they cannot move their legs, we have to assume that it's in the spinal column or interthecal. So now, once they know that they're in the right place, they are going to give a bolus of medication, usually lidocaine, some type of cane, and fentanyl, so that it starts the process, and then you will have a continuous infusion of a PCEA according to how much the patient needs. We want them to have a light epidural that they can feel pressure but not pain. Okay, so that was anesthesia, epidural, and you can go back and listen to Cal Shipley. I was just trying to give you the big parts because it would not let me record Cal on this. So after the procedure, or during the procedure, you're going to monitor the heart rate during the test dose, make sure that the patient is safe, make sure that the partner is safe, and then afterwards, you're going to monitor the patient's heart rate, the blood pressure, and the O2 stat continually during the duration of epidural anesthesia, because we know that there is a potential for hypotension and decreased oxygen to the baby. Bladder care, some institutions will put in a Foley catheter as soon as you get your epidural and then pull the Foley catheter at the time of pushing. The reason we pull the Foley catheter is because there is a balloon which can really act as a barricade from the baby's head coming down. Some institutions do straight casts. You know, it's a risk to benefit. With a Foley, you decrease the risk for infection, but you increase the risk for trauma because it's a larger diameter of a catheter. With a straight cath, it's a smaller diameter of a catheter, but you do run the risk of introducing more infection because you have to usually do it multiple times. The patient usually is, we ask them to void before the epidural, and then of course they need to be cath every 1 to 4 hours following epidural administration. After the epidural is completed, we need to make sure that the patient voids as well. So the patient should never go 4 hours without being catheterized. Safety, put the cell rails up ×2, bed in lowest position, call bell in reach, and we're always going to have continuous fetal monitoring. Oops, sorry about that. Continuous fetal monitoring. And that is because we know that we have the potential for hypotension and decreased oxygenation to the baby. So epidural anesthesia, we discussed that, and that's lumbar anesthesia. Combined spinal epidural anesthesia, this was popular back in the early 2000s, where they would give just a small dose of fentanyl into the spinal column, pull back on the needle, and then thread the epidural catheter into the epidural space. They called this a walking epidural, which was, you know, it was good for pain relief, but we had some problems with patients wanting to walk when they had anesthesia on board. So that was not really a great thing, and you don't see many hospitals employing that. Epidural and intrathecal opioids, of course, that's when you would go into the spinal space. Contraindications to epidural space, to epidural blocks, we've already talked about. The epidural effects on the newborn, if there's hypotension, we know that's a huge problem. However, I do want to say that people say that the baby gets very little of the epidural medication. That is true, but we have seen decreased scores on breastfeeding readiness after delivery for patients with epidural anesthesia. Are they just a small bit lower? Yes, but we have pulled cords. We do cord bloods on in studies. We pulled cord bloods, and we find that the baby does get a very, very, very small amount of the fentanyl that's used during the epidural procedure. So we can't say the baby gets nothing. Nitrous oxide for analgesia is absolutely wonderful. The NAS provides this, and UF North provides this, and it's just like going to the dentist, and during the contraction you have the nitrous on board. Very, very, very little gets to the baby. It's almost all gone by the time it even gets into the maternal system. So we really like the nitrous oxide. And then of course general anesthesia is when the patient, for an emergency C-section, when the patient has to go completely out. Sometimes you'll be in surgery and they will ask for cricoid pressure. You find the cricoid ring, you press down. This would be in an emergent situation. And so anesthesia is getting ready to intubate. They'll ask for cricoid pressure. This pushes the cricoid ring down and thusly occludes the esophagus and prevents aspiration of the GI, of the esophageal contents or stomach contents into the trachea. And you can see that pressure occludes the esophagus. So sometimes anesthesia will ask you for cricoid pressure. Care management, we really talked about informed consent for anesthesia, timing of administration. We really like for the patient to be 3 to 4 centimeters dilated before getting epidural anesthesia, and we want them to get the lightest dose as possible. Of course, we talked about IV, IM medication and safety in general. So you guys just remember that we don't want any IV medication on board that can get to the baby within 1 hour of delivery, because we worry about respiratory depression in the newborn. Narcan, we always need that to reverse opioids, but be very, very cautious, because there is a lot of concealed opioid use that we do not know about, and if we give the patient a little too much, we may have a reversal of what they have already been doing throughout their pregnancy and during this visit. And then epidural anesthesia and non-pharm relief is very important. General anesthesia is rarely used for vaginal birth and is most often used when they can't get in a spinal for a routine or repeat C-section, or if there's emergency anesthesia. Thank you very much for listening.